To order, and I'm going to ask Councilor Buzzer to give the invocation, please.
Dear Heavenly Father, as we gather here today to conduct the business of the Cherokee Nation, we ask that you give us guidance. We also ask your blessings on the Cherokee people, on our governments. We ask you to keep your hand upon our troops that serves overseas and those in the United States. We ask all this in Christ's name. Amen.
Amen. Next is roll call.
Bradley Cobb.
Honey.
Janelle Fulbright. Bill Englund.
Here.
Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Julia Coates. Joe Crittenden. Jody Fishinghawk. Don Garvin.
Honey.
Chuck Hoskin Jr.
Here.
Tina Glory Jordan.
Present.
David Thornton.
Here.
We do have a quorum.
Thank you. Next is new business. Obviously, there's none since this is our first subcommittee meeting. Well, I should have said old business, my fault. New business. What we're here to talk about is health insurance regarding citizens. And I'm kind of tell you what I wanted to accomplish today. And if y'all feel like there's something else you need to accomplish, or this is more of a fact-finding mission. This has been talked about, researched in some aspect or form by several people, including the health group, over the last several years. And I think we're kind of at a point where I think the ability for citizens to access health coverage at a reasonable rate, reasonable meaning large group policies, those kind of things, is more possible than it has been in the last 4 or 5 years. There's some, in the next meeting that we have, and we'll set that at the end of this meeting, I think we're going to bring some people in and kind of talk about the semantics and the logistics of how that would possibly work, and see what is the pleasure of this council, how to proceed from that point. But today what I really wanted to do is sit down and talk about what's important for your constituents. What do you envision? Because we're all from different areas of the nation and outside the nation. And what's important, what do you feel like is an important aspect for your constituents? What do you hear about health insurance? Obviously we have access to our clinics, but one thing, an example to talk about is when we run into contract health issues and those kind of things. As you're well aware, from an IHS perspective, we are grossly underfunded for contract health. So some of the things that I originally had thought about, and I wasn't the first person to do this, and I'm sure I won't be the last, but when you work for a major corporation, you have the ability to buy health insurance at a much more favorable rate, and you have options, and that's really where I want to go with this, is options. Right now, you as a citizen, you can access clinics and IHS, but as far as major medical and those kind of things, you don't have really an option. You're in the system and that's it. So what I really wanted to do is kind of go around the table and tell me, as far as health insurance for your constituents, what's important. What do you view as important? What is the final goal in your mind? So I will open that up to somebody who wants to kind of start and tell me what they see. And please, Councilor Baker from at-largedom.
Yes. Well, of course, since so many of our Cherokee citizens, almost 2/3 live outside the nation, although probably half of them are not within the service area or readily available to the service area handled by the Cherokee Nation clinics and hospitals. Then they do need some type of health coverage. I was in Phoenix and Tucson this weekend for their kickoff meetings, and that's one of the ladies came to me and was really concerned about the Indian Health Service and the poor quality of the Indian Health Service in Arizona. I said, well, it's just beginning, but we're going to start discussing the possibility of a group insurance, people that you could get. I said, it certainly won't be free. You'll still have to pay for it, and hopefully at a lower rate than otherwise.
Right?
So I see that this could help probably at least half the Cherokee people living outside or away from the nation. So that's basically what I would like to see, is reduce rates.
Reduce rates outside of the nation. Melissa, I know you just came in. Did you have anything you want to talk about or add or kind of discuss? You're welcome to the floor if you want to. We just started basically. I'm just a fact-finding mission. What's important, and if you have anything you want to say from the health side of it, feel free to step up there.
Well, I could just say a little bit. You know, this is something that I've tried to work on now for many years, and Dr. Cobb and I have had lots of discussions about it for several years, probably the last 5 years or so. And, you know, there's always been, there's been some difficult barriers with it. I've been recently excited because I've recently met a Cherokee citizen that might be in a position to help us develop this. So, and I had Dr. Cobb to meet him this morning. So I'm excited about the possibility. You know, I'd like to hear more about what, in response to what you said. You know, I think different people have different ideas about what reduced rates might be. And so I'd like to hear some thoughts about some explanation into those kinds of things, because, you know, if you go on the market and just try to get a comprehensive health care plan, it's going to cost you $500-600 a month probably. You know, a reduced rate might be what we're calling a group rate. You know, might be down around $400, but that's still very expensive for a lot of people. And so you have to just think about different target populations and what those needs are. And so anyway, that's all I have to say. I'll be glad to try to, you know, answer any questions that I may or may not know at this point. I think it's very preliminary, and, you know, it's going to take us at least a year or so to work all the issues out. But
Councilor Hosmer.
I mean, that's kind of what comes to my mind, is what do we know about our population who doesn't have access to health insurance through an employer, so they would either buy it on the open market or do without health insurance. I mean, most of them, just anecdotally, most of the folks I know that are in that situation can almost afford nothing, really. And so I guess that, I mean, obviously that's going to influence what our target is. I know we're in the preliminary stages, so I don't expect any real concrete figures to be tossed around, but do we know anything about
we
this
don't. I mean,
situation?
what we know about is our patient population. That's what we know about. I mean, currently we don't have any mechanisms to gather that type of information about our citizenry as a whole. You know, the state of Oklahoma, we know things because we've been working on, you know, universal health care coverage for the state of Oklahoma for a long time, and you can extrapolate percentages and all those kinds of things. And that's what we talked about this morning. You know, I think we have people they're just never going to be able to afford health insurance if there's not, you know, their employer's not paying half of it or those types of things, because, you know, you live paycheck to paycheck. And is this product going to be able to help those type of people? You know, I can't say that now because I don't know what the product is yet, but I just think we have a varying range of various you know, pockets of people that we want to try to assist, and how do we best do that?
That's a fair response. The other question I had is, at some point there's going to be a subsidy that kicks in under this healthcare law for people to buy.
2014.
Yeah, so I mean, even though, so Native Americans don't have the individual mandate, is that correct?
That's correct.
But they still would have access to the subsidy if they were buying insurance on the open market. Is that?
We believe so, yes. And you know, we talked about that this morning too. And, you know, we're going to try to talk to the lawmakers and the powers that be to see if there's a possibility, you know, to have just an exchange available for Native Americans. which could capitalize on some subsidy. So, I mean, I think there's lots of opportunities. We just got to start working through those and
You might.
just, fleshing some of that out.
Stay up, if you might, and you still have the floor, Councilor Hoskin. I just want to interject something. You might, those of us that do this for a living, you might talk about a little bit about that exchange and talk about what happens in 2014, kind of where we're coming up. I'm not looking for a lot of detail specifically with us. I'm talking about from the federal side. You may talk about that a little bit because they may not be aware of that.
Well, just disclaimer, I'm no expert in this, okay? So, but I'm trying to wade through it as everybody in the health field is right now. But, the concept of a health information exchange is a place where what I would call a clearinghouse, so to speak, for what are all the options available to a certain individual or group of people for health insurance coverage of some sort. And, there's products currently available through the state of Oklahoma, through Insure Oklahoma, which we've worked on in health services actually a lot, trying to work with our tarot businesses and other people to make them aware that as an employer they can capitalize on these products, or as an individual employee they can. So from a federal level, the healthcare reform law ask all of the states to develop health information exchanges for their states and to make those available by 2014, I think it is. And so right now in the state of Oklahoma, that's been a little controversy, and I think we aren't anywhere near knowing what the outcome of that's going to be, whether we're going as a state to go ahead and develop that and be ready for 2014, or are we going to not do that and have a whole different position on it. That's probably yet to be seen by our current state administration and legislature. So we'll see where that goes. But, I think Dr. Cobb and I have talked about, wouldn't it be a great thing if the tribe had a health information exchange, so to speak, for our citizenry at least, and be able to be on the front line and act as some sort of model for that.
You still have the floor.
You mentioned the 2014, the exchange. If the state of Oklahoma doesn't develop its own exchange, there's going to be an exchange, the federal exchange. It's just not going to be the state's creature. Well, that's all I have.
Councilor Jordan.
Melissa, on that $54 million that the state of Oklahoma was going to get to create their exchange system, is there a possibility, since it looks like they're going to try to turn it back, that the tribes could all go together and get some of that money, and then the tribes all together, all of our tribes in Oklahoma, develop our own exchange, much as you were talking about maybe just Cherokee Nation doing it? Could we capture that money? Is there that possibility there if the state wants to give it back? Can we use our people in Washington to try to capture it and develop our own exchange?
I don't know the answer to that, but it's definitely a thought.
Because it appears to me that what they're doing in Oklahoma City, that they're going to give it back. Even though Fallon's trying to take it, I think that the legislative body is trying to give it back. They just don't want to be seen as buying into any of the healthcare law that has come into effect. But I wish we could capture it. Maybe we could get y'all to go up there and see if we can get some of
Well,
it.
we're definitely exploring some of those opportunities. I mean, I think it's kind of on the verge, because it's almost too soon right now because they haven't officially done anything. But, I think they're having some intense meetings this week to try to decide what to do. So we're definitely exploring those opportunities.
I just wish we could get it. And like you say, have a model for the rest of the state.
Councilor Garvin.
Yes, thank you. Melissa, in general, in our clinics and hospitals, about what percent have insurance now?
About 55% of our patient population has
Sorry, you're on mic.
About 55%, give or take, depends on what site, but as a collective whole, about 55% of our population has a third-party resource. So that means they either have Medicare, Medicaid, or private insurance.
Yeah.
And I don't want to quote the exact amount that's private insurance, but I think it's around 20 to 22%, somewhere around in there. That's private insurance of our patients.
What percent of our people are non-workers? Do not work?
I don't know that. I don't know that off the top of my head. I can imagine that our Commerce Department might have some of those numbers.
Thank you, Mr. Chairman.
Does anybody have any thoughts on how this goes, how this ties into our current health system? That's one thing I wanted to talk about. Does anybody thought about that? Because, Councilor Hoskin brought up a great point in that, who's going to be able to access it, what percentage of the population just will have the means to access this. And if it's a possibility that a group health insurance is able to be taken at our clinics and our facilities, those are more dollars available for those facilities for the people that can't. So it's a kind of a win-win situation. That's kind of where I'm going with that. So does anybody have any thoughts on that, or tell me what's important to? I know Councilor Fulbright. I know one of your concerns has always been diabetes. I know Councilor Watts is not here. One of her concerns has been coverage for autism and some other situations. Anybody else besides diabetes, autism? I mean, because ultimately those are some of the questions that I'm asking. Is you're looking at health insurance when you write those policies. There's always exclusions, and there are certain things that can be included in those. So if it's not today, what I want you to be thinking about is when those policies are written, unless it's specifically stated in those policies that this coverage, or you have the opportunity to pay at this rate for this coverage, it's not covered. So, did you have a question? I'm sorry. I don't know if you raised your hand or not. So, if not today, I want you to be thinking about those things. What's important? Because I've been approached, obviously Councilor Fulbright has mentioned diabetic coverage in her area, and Councilor Watts has talked about and actually there's some interesting articles about some insurance rates and insurance companies and autism. Home health care is another situation. Don't just assume because you have health coverage that home health is included in that. So those kind of things that we need to be thinking about. Yes, ma'am.
I'll
Councilor.
just put it out there that I would be interested in things that were focused very much on preventative rather than at the back end of the problem. And I'd also be interested in exploring some sort of non-traditional coverages for things like acupuncture and some different kinds of therapies that might not be considered strictly medical by Western terms. So I'll just offer that.
Okay. Anybody else? Is that a yes or a no? Yeah, Councilor Buzzard.
This is a big task, and I really think that, and Melissa probably can help us, you probably could too, Dr. Cobb. I think you could find a broker or a person from a large insurance firm that would come down and talk to us about it. Now, and I'll say this, it's just like when we were talking about redistricting, we didn't have somebody that did redistricting as for a living. So I think we need to have somebody from some insurance company to come down here and talk about this. They could certainly get us on maybe a right track on what we need to start looking and the questions that we need to ask. So
We met this morning with
Okay.
someone and slowly putting a plan together, and I plan on bringing that individual in, if not next meeting, then the next one after that, and kind of talk about several different paths we can go down. It could involve something like a pilot program in 1 or 2 spots of the nation. But we're gonna bring that person in. That was just kind of a preliminary meeting. Essentially, he was asking some of the questions I'm asking y'all and kind of getting a feel for what we were looking at. But it boiled down to that whole exchange in 2014, and I think Councilor Jordan has a great question, because that question came up this morning in that meeting, was exactly that, as far as, exchange and not only the Cherokees, but all the tribes in the state of Oklahoma. Again, I've said over my 4 years that the state of Oklahoma has some unique opportunities in a win-win type situation for the state and the tribes, but we've got to kind of grasp at those. Did you have your hand up? Oh, I'm sorry, were you finished?
One
Go
more,
ahead.
just a thought is, like Walmart, I wonder, and I don't know if they give insurance to all their employees or not, probably not. I don't know if some of the other larger companies, but I wonder how they go about doing that. And like some of the big Fortune 500 companies that has 10,000 employees, do they go back and check with each family as to what their medical history is?
They do what's called actuaries, and
Okay,
that is
so they do the
ultimately
actuaries,
where we
huh?
run into some problems, is that, and Melissa, if you want to step in, we can give you percentages at our clinics.
Yeah.
Okay, but if you're gonna ask to specifically break down the number of diabetics, the number of, heart patients, high blood pressure, Cherokee citizens, we don't have that ability, because we don't do it that way at our clinics. We don't just, I guess you could wind through every single record, but I didn't think you could do it that way. We can't break it down per citizen, and that's what has always limited the discussions over the last 4 or 5 years. Is you'll get an insurance company and they get excited about seeing that number of people, and then all of a sudden they run into these actuaries and they're like, oh, well, and then the whole conversation just fizzles from there. So go ahead, I'm sorry.
That's it.
Councilor Hoskin.
Well, that was my question is, do we know whether we can gather this data on our people to do those actuaries? Do we need to change anything in our procedures or our law that allows us to gather that information, or?
Well, I don't want to, and you can stand up, and I don't want to come out and say, well, I don't think that's going to be a problem, but I think there's a way to move forward through that, for lack of a better.
At this point, it's really too soon to tell exactly what we're gonna have to do, because it's just preliminary talks. But we're gonna try to not have to do that. We're gonna try to figure out a way where that's not a barrier.
I like her.
It has been encouraging. It has been encouraging. So, Councilor Baker brought up at-large coverage for citizens outside the nation. I think that's a goal, down in the bigger picture goal. Councilor Coates is, and we actually had that discussion today about preventative. This was kind of an interesting discussion. I was pleased to hear some of the thoughts on that. Non-traditional didn't come up, but I'll definitely pass that along. Councilor Buzzard, I got your questions about, large company, how they do that, and actuaries, and Councilor Hoskin, I've kind of heard where you are from the logistical side of it. And what I want to do is eventually bring, when we get a little bit further down the line, bring some of these people in and point out what some of the obstacles are and what the options are of moving around these obstacles. But right now, I've been kind of encouraged that somebody's willing to take these obstacles on. What I wanted to do today was find out what's important to y'all. So unless somebody else has anything, I'm gonna wind it down. Any more? And be thinking, be thinking about, I do want to meet again, and I want to kind of hear, with an insurance, what you expect for the citizenry, what you expect it to do within our clinics, because that's a big chunk of third-party revenue, what you expect on that. So if there's nothing else, I would like to set the next meeting May 16th at 1:30 PM. And that, without any further ado, I'll ask for a move for adjournment. Anybody has anything? There's a first,
So moved.
there's a second. We are adjourned.